So let me ask the panel, newly diagnosed ALK patient in your clinic today, what would you use first line?
So based on what's approved, crizotinib.
Okay.
Crizotinib.
Crizotinib with some guilt that perhaps I should be using alectinib.
No CNS disease.
Okay, crizotinib.
Okay. Okay, so crizotinib remains the standard. We have second line options, and the patient 10 months later progresses. What are you typically doing second line?
Alectinib.
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 And is it based on toxicity?
Yes.
Not necessarily a perception that there's a difference in efficacy.
Correct.
Fair statement.
Absolutely.
Fair.
Okay. So with ceritinib, I mentioned before that we had the two profile trials that with crizotinib against standard care. And then we saw, again, at the World Lung Meeting, ASCEND-4, which was a trial of ceritinib versus standard chemo. Could you walk us through that? I think this is important data. I'm not sure how to apply this in practice because I don't know that the comparator is chemo at this point, but tell us about the data.
So this was a comparison of standard of care chemotherapy versus ceritinib in the first line treatment-naive patients. Definitive trial to prove the point that the drug is superior to standard chemotherapy. And it was. The data was quite convincing. Progression-free survival was 16.6 months for ceritinib versus 8.1 months for chemotherapy. And the hazard ratio was an impressive 0.5 or so. Overall survival also was favoring ceritinib. The stumbling point of this data is a little bit the toxicity profile because it was used with standard dosing, 750. So there was significant discontinuation rate. About 69% of the patients had dose adjustments, which is significant. We know that's what's happening in our practice. So the question of whether we should adopt ceritinib based on data, comparing it to chemotherapy as a first-line treatment versus crizotinib is not easy to answer based on this data. They are impressive data, and 16 months is very long progression-free survival. We haven't seen that.
Yeah. So did they present? You know, we have as part of the, I like to call it as part of the afatinib story. You know, we do have the analysis of the Lux-Lung 3 and 6, I believe, where they looked at those patients that required dose reduction and didn't see any decay of efficacy in those patients if you had to go down to 30 or 20. Did they talk about that at all in ASCEND-4 in terms of looking at those, since the majority of the patients had to be dose reduced?
It was not really discussed, but I'm hoping that it is in the database. I haven't seen it. So we don't really know, but in our clinical practice in the second line setting, dose reduction does not really affect activity of the drug, so I wouldn't be expecting it.
Right, right. And the other trial that was very exciting at ASCO last year, to turn the clock back to as we get closer to ASCO 2017, ASCO 2016, we saw the J-ALEX trial, which was a first head-to-head comparison in this disease setting of crizotinib, the standard, and alectinib.
Right.
Your thoughts around
this is the study that explains Jared's guilt, why he feels guilty when he uses crizotinib in the first-line setting. And this was a study that was done completely within Japan, about 200 patients. They were randomly assigned to either standard crizotinib, at the standard doses that we use, 250 milligrams twice a day, versus alectinib at the Japanese standard dose, which is half the dose of what we use. And in this study, the alectinib won by a long shot. The hazard ratio for progression-free survival was 0.3. So the progression-free survival median for crizotinib was what we'd expect to see, about 10 months, and it hadn't even been reached for the alectinib. So this was a dramatic benefit with a drug that has good CNS penetration, which is also a concern in these patients and why we're tempted to use this. Now, will this apply to a non-Japanese patient population? The global ALEX study has completed accrual, and we're waiting for data on that. So a lot of us are waiting for that data before we begin using alectinib as our standard go-to first line. There, of course, also is the issue that alectinib is not yet approved first line, so you have to fight with the insurance companies in order to get it.
Yeah, one other thing from that data that helps drive my guilt was the superior toxicity profile of alectinib in that study.
But talk about dose.
Right. So it
Right.
was half the dose that we typically.
In a Japanese population, which may be appropriate, but it was half the dose. I don't know if that makes a difference, but yeah.
And the crizotinib came out pretty bad, actually. I mean,
did.
crizotinib
Yeah.
does
It
have
did.
some challenging toxicities, but generally when I use it, it's pretty tolerable.
I
But
agree.
there
It
they
looked
had a
worse
really
than in
high rates of
practice.
dysgeusia, which I've only seen a handful of times. They had the visual disturbances. The only thing
GI
that the
was pretty
people on the alectinib was some constipation, and they tolerated it much better. So, but I don't know in our hands if that's if I get that impression that crizotinib's so hard to tolerate.
Yeah, I think Alex will help a lot there.
So you're all using crizotinib for the newly diagnosed patient, but is there a patient that you would use alectinib before crizotinib in your practice today? I know what you're going to say.
I already have discussed this with you, Mark. I think the CNS activity of alectinib is very impressive. So the patient that has asymptomatic brain metastasis at presentation, or even a patient that has been treated preemptively with stereotactic radiation therapy before it was discovered that they had the ALK gene fusion, may be a very reasonable candidate for alectinib upfront.
Others?
Yeah, same thing. Patient with brain metastases, I would try to get alectinib if possible. And by what's written in the label, if you have someone for some strange reason that can't tolerate the crizotinib, you are allowed to give the alectinib.
So do you have a lot of people who can't tolerate
No,
crizotinib?
no.
Okay.
And I think actually in that trial, it was probably a factor of people just being more vigilant and familiar with crizotinib and thus annotating the toxicities, which is why you saw much more than is apparent clinically.
Right.
Yeah.